So our next speaker is Professor Kate Drummond. Dr. Drummond's the Director of the Department of Neurosurgery at the Royal Melbourne Hospital, and Kate will speak to us this afternoon online supportive care. Thanks, Kate.
So can everyone see my slides and hear me talking? Excellent. So look, I mean, what a wonderful example we've just seen of supportive care in place and very associated with place. We know that the pandemic has changed that a little bit, but also both for Canada and for Australia, big countries, relatively small populations, and patients who may be limited in their ability to drive, to travel, maybe a long way away from a brain tumour centre. And so we've really been thinking about how we can augment or even replace in-person supportive care with a technology solution. And this is sort of the description of the $2.6 million MRFF grant that we've just received to develop this platform, and you can see our partners there. So it comes on the back of 10 years, really, of research in quality of life for me. So we've published on multiple tumour types that patients with brain tumours have reduced quality of life compared to a normal population, and that this is persistent, that it persists for months to years after diagnosis if the patient is alive for months to years after diagnosis. So this is just, a very simple graph of our results from our low-grade glioma patient. It's the score on a quality of life survey called the QLQC30, a cancer quality of life survey. The light blue are the scores that you would expect from a normal population. So even a normal population doesn't have perfect health-related quality of life. They've all got a cold or a hangnail or a headache or something that's reducing their quality of life. But our low-grade glioma patient has reduced scores on health-related quality of life, particularly related to role function, their ability to function in their normal social roles, emotional function, cognitive function, social function, a little less, interestingly, in physical function, and in overall global health-related quality of life. And this is, from 576 questionnaires from, a large number of patients. And we know if we map these over time, so another bunch of complicated graphs, but basically this is the same, the score on the QLQC30. The orange is the line that you would expect the score for the normal population. The blue is the score from our low-grade glioma patient cohort, and the grey is what we call the minimally clinically important difference. The reduction in quality of life from normal that the patient would actually notice and find to be real, because a drop of the score from 99 to 98 is not significant, but from 99 to 89 is significant. And you can see that for global quality of life, for emotional function, particularly for cognitive function, the feeling that your brain is not working, social function, and for symptoms like fatigue or sleep, there is a prolonged and significant abnormality in our brain, our low-grade glioma patients. But these are things we often don't talk about. Who goes to their brain tumour clinic and someone talks to them about fatigue, or are you sleeping well, for instance, or how do you think your brain's functioning? We're, neurosurgeons, we're pretty awful. It's a pretty blunt instrument. Can you walk? Can you talk? So, these things are things that we need to pay attention to. And it's not just the primary intrinsic or tumours within the brain that have this problem. Even small meningiomas, patients often feel that their quality of life is reduced, and we've published on this as well. Here's the same graph for meningioma: quality of life, physical function, role function, emotional function, cognitive function. Interesting, for a tumour that's not even in the brain, is on the surface of the brain, and social function reduced over time. So the same graph, the grey is the normal population. The dotted line is the clinically meaningful difference, the amount that you have to drop to notice it. And we see that quality of life over time, over up to 120 months, emotional function, cognitive function in particular, even right out at 120 months, patients scoring themselves 60 out of 100. Social function, fatigue, significantly poor fatigue and significantly poor sleep. So we know there's a problem, and we've proven this with our research. So this is a picture of Heidi McAlpine, one of my trainees and now a PhD student. She'll be a neurosurgeon and have a PhD in gliomas as they grow within the electrical environment of the brain. Also was interested in improving quality of life or supportive care, and that we might be able to do this online because, you know, we were kind of failing in person for a number of reasons. So we started a 3-phase project that she's really driven. And we started this with a literature review, then surveying our own patients, and then the grant really to develop the online community. So our literature review, which we've published, you know, we looked at online interventions for supportive care. We couldn't review brain tumour because there weren't really any articles, but for cancer patients in general. And this wasn't just, we built a website and we asked people if they liked it and they said yes. This was, we built something online and we tested it and to see if it worked, before and after, or a control group or something that told us that it actually made a difference to patients. We looked through the literature and we came up with, you know, 1441 articles. We came down to 56 that we assessed because we thought they might be eligible. And in the end, we found 14 studies, only 14 studies where someone had built an online intervention and they'd proven what effect, or they'd rigorously assessed what effect it had. And what did we find out? Well, it was pretty disappointing, actually. We found out that a small number of patients, a small number of interventions actually made a difference. Many made no difference at all. And worse still, some actually made patients feel worse. So we thought, okay, we probably need to think about this a little bit more clearly. We did exactly the same as the quality of life research that we've done, which it was been performed by an army of medical students going out into our brain tumour clinic waiting room with a clipboard and assessing everyone's quality of life after they gave us their consent. We did exactly the same, looking at how our patients use social media or online platforms for specifically for management or in connection related to their brain tumour. So, you know, not just people who use Facebook to catch up with friends, but people who use it specifically for their brain tumour. And we've obviously just published this as well. So we surveyed 200 patients. Well, what did we find out? We actually found out some really interesting things, which really crystallised for us that we need something online. You know, 34% of our patients live more than 50 kilometres from the hospital. That's a long way to come for some sort of supportive care, you know, a support group or you know, some sort of a course or whatever. 46% didn't drive. 36% were not partnered in any way. So socially isolated, and 71% not working. So socially isolated, geographically isolated, and, you know, very difficult to obviously to access services related to supportive care that were really place-based. And this was something we'd learnt when we tried to run support groups, where, you know, many patients couldn't make it to the group for a variety of reasons and therefore missed out. So that encouraged us. We found, though, that, of course, there are a lot of patients, we had, you know, 14% of patients didn't use the internet at all. And of patients who were internet users, only 71% of those were social media users. And on the non-social media users, why did they not use them? Well, really, lack of knowledge was one part, but 70% were scared that their information wouldn't be private. So that really taught us about, you know, how we had to build this. And people didn't use it super often, but 20% of people daily, many monthly, some less than monthly. So a bit of a mixed bag, that an online intervention would target some patients, but perhaps not others. And you might think that perhaps the younger and more tech savvy, although a lot of older patients, of course, have the time to become very tech savvy. So what did we learn from this? You know, there's a lot more data in this study, but what did we learn that patients wanted for an online intervention for brain tumour patients? Well, they wanted the ability to control the amount and type of information that others knew about them. Makes sense. They wanted to use it at any time and location. That's obvious. They wanted to use it as a guide or a filter for useful information. There's a lot of crazy stuff out there, you know, on the internet and in forums and chat rooms and patient forums and Facebook. And it's really hard to filter what's useful information. So they really wanted something that would help them filter useful information. They really valued if there was a health professional either moderating or contributing. And they really wanted the ability to share experiences, especially access the experiences of others, which is a bit of an imbalance there. They wanted others' experiences, but not necessarily to share their own, but they particularly liked the blog format. So these were very useful, and all of this research really crystallised in our application to build our online platform. And the online platform, it's got 3 pillars on one side and 3 pillars on the other side. So on one side, the pillars are patients, carers, and clinicians of all varieties. You know, of all varieties, not just doctors, but allied health and other clinicians. And the 3 pillars of our solution would be connection with the treating team. You know, patients we know have a lot of trouble finding the person they need to talk to. And I'm sure that's the administrative assistant that we've just heard of, but enhanced connectivity with the cancer nurse. The ability to say access a Friday afternoon chat group with your cancer nurse, or your brain tumour nurse. And an ability to access multidisciplinary care from diagnosis to end of life. The ability to have peer support, and we really saw that as almost targeted peer support. You know, we've all been in brain tumour groups when perhaps the high-grade glioma patients and the low-grade glioma patients really don't fit together in the same group. Younger patients, a young mother with a family might find fitting into a group which is old, a bunch of older patients facing different challenges is not what will be really helpful. So the idea that we could have this eventually go national and have peer group supporters for rural patients, for young patients, for different tumour types, for rare tumours, for adolescent and young adult patients was really an important challenge. And the second one was symptom management. This was key. Are we able to deliver treatment for determinants of quality of life on our platform? And what we've chosen to concentrate on in the prototype is sleep. So a cognitive behavioural therapy intervention to manage sleep disturbance. But of course, if this works and if we are able to deliver meaningful interventions, then this will mean that we can grow this into the future. Of course, we've been really informed by definitions and understandings of the unmet need in supportive care, which we've defined as the prevention and management of the adverse effects of cancer and its treatment. This slide is from Mai Krishnaswamy, Chair of Cancer Nursing at Peter MacCallum Cancer Centre, who is one of the CIs on our grant. And her definition of supportive care and the unmet needs really melds very nicely with what we intend on doing. So supportive care screening, rehab or symptom intervention, families and carers both able to access supportive groups. And I didn't mention that, but that would be, of course, one of the important support groups that we would be able to apply and be able to have psychology, rehabilitation, etc. In our platform. So how are we going to build it? Well, there's a couple of fairly complicated slides here, but basically the basic principles are we have a digital platform provider, Two Bulls, who've made many award-winning healthcare associated digital platforms. We partner with the Centre for the Digital Transformation of Health at the University of Melbourne, and the basic tenet is co-design. So at every aspect of design of this platform, it will be co-designed with patients, carers, and the clinicians who will use it. And so we've got a 1-year prototype development phase, which we're in the middle of at the moment. Two Bulls have done a number of sort of basic, what would you want with the tech interviews with patients and carers and clinicians. The Centre for the Digital Transformation of Health is now doing some deep interviews for the co-design process with patients, carers and clinicians. And then there'll be these living labs where we really test what we've found out. And then we'll have a 2-year intervention, delivery and evaluation and implementation phase, which again, you can see here, a needs analysis, really this co-design iterative process with an iterative platform, which we will then implement and evaluate to transform the standard of care. And of course, we're doing this in Victoria, but we would love it to become national. And this is new knowledge, you know, for drug development. I'm sure you've heard this morning from say, Jim Whittle, who's also one of our collaborators. You know, we have to discover and develop the drug. We do preclinical testing in animals and safety, and then there's phase 1, 2, 3, phase 4. It gets regulated and approved by the government, and it goes into the community. For digital health innovations, we've got discovery and development, and then we've got this black box. Well, I've got a grey box here. I should probably change it to black box as to how do we evaluate that it's going to work and it's going to help our patients. And we do hope that our research will fill in the grey box to help our better understanding of implementing and evaluating digital health innovations. So that's, you know, really all I want to talk about, and I think that we'll be having some questions later. So we will be later in, you know, a sort of a year down the track, which is about 7 months down the track now for the project. We'll be looking for 200 people as part of the iterative feedback and development process. So hopefully some of you who are listening there may be able to be involved in that process, and we would certainly welcome you.